He had various problems in life, and he's been a very supporting elder brother to me on this. And besides that, for all our neurosurgical reference is always there. Even sometimes in the middle of the night, he would come in and see patients who had neurological problems. He has very long working hours, and he's kind enough, even in spite of his long training, to come and share his experiences with us regarding patient involvement. Our entire team in the spine surgery department of Australia was Australian because on many occasions he has helped us out and cleared us out of many neurological problems. I welcome you today and the way this lecture will go on is we will be basically speaking on anatomy and physiology of normal body, which we as spine surgeons really need to know. Then we will go on to evaluation of neurogenic bladder, that means clinical as well as the current imaging modalities, including he will share some thoughts for neuroscopic neurodynamic studies and the two studies which we usually do not know much about, and I think all spine surgeons should have probably been understanding the basics of neuroscopic neurodynamic studies. And the third part of his talk will be dedicated to the treatment. I understand that neurosurgical modalities and the nitty-gritties of neurosurgical, the surgical part of it would not be a big deal for us. But you spend some time in medical management, drugs used on, followed by that, share clinical cases. And after that, I have one case which is being lined up for today's case, which is a complication which I had, a disastrous complication, and to show you how neurological problems can be there out there in spine practice. Without standing a lot to you and Pollanda, it's my great pleasure to initiate this talk.
Very good evening to all of you. Thank you, Shomojit, and my respects to Indrajit Da. These are the mentors who Indrajit Da has been a great mentor, and Shomojit has been a wonderful colleague. And this, along with several other neurologists and neurosurgeons in the city, have referred their patients to me. And this has been a source of education. I was forced to develop, not forced, I loved neurodynamics from the very beginning. You know, I'm very much a generalist. I come from a generation where there were no super specialists, but during my training years, neurodynamics was emerging in the Western world as a diagnostic tool. And therein lies my sort of claim to be standing up here and talking to you. Because after I came back to the city over the last 25 years, I've actually managed started 4 different neurodynamic units in different parts of the city. And naturally, you get referred patients. And neurodynamics is a wonderful way to understand the physiology of the bladder and correlate with symptoms to a point that when you become proficient in your symptoms, then you don't need neurodynamics. You can listen to a patient very carefully and you can treat him. So if there's one message I'm going to tell you today, that for neurological, nomenclature, neurogenic bladder was the nomenclature I was given. But really the buzzword these days is NLUTD, neurological urinary tract, lower urinary tract dysfunction, NLUTD. So it's a common problem. And what I'll try to tell you is that it's very easily possible to come to logical treatment decisions with common sense, good clinical history, and of course aided by some investigations. And then, if possible, we'll go through some cases which Shomojit and others have referred to me and which I've managed in my time. So, this is for the junior trainees. Man can live without his bladder. Bladder is, however, in the course of evolution, the bladder has a muscle, and it's really a part of the motor system and voluntary motor system. And even some animals have used urine as a territorial marker or for sexual attraction within the species. So really, as evolution happened, uh, the bladder center, which you all know is in the sacral part of the spinal cord, it began to be controlled by the higher reaches of the neural system. And one of the giants in the field of bladder physiology is a man called Holsteek, Gert Holsteek, who's in the Netherlands. And he demonstrated that the bladder center in the bladder is controlled by the pontine micturition center. This was the work of Barrington in the 1920s on cats, on decerebrated cats. And then Holsteek diagnosed a lot of thereby proving that the pontine micturition center was the bladder afferents going up to the pontine micturition center, then went up to the aqueductal gray, and then to the frontal lobe. And there was an emotional aspect to control of the bladder. So that is very important. And this, many neurosurgeons like Indrajit will be able to tell us that in the 1960s, people began to realize that, as you know, the frontal lobe, patients who had their frontal lobes removed developed complete loss of bladder control. So that's a different issue. I'm not going to go into that, but today's discussion is on the spine. But what I really want to tell you is that the prefrontal lobe and the insular cortex, the interoceptive cortex, gives all of us the sensation of bladder as an organ. So this is very important because when you have a spinal cord injury, all the tracts in the spinal cord are cut off, and then alternative reflex arcs develop. And your job and my job is to rehabilitate the patients from this sort of insult. So, these are functional magnetic resonance imaging has demonstrated that there are connections in the frontal lobe. So really, Gert Holsteek, I referred to him again, he wrote a very nice editorial in the Journal of Comparative Neurology that micturition was controlled by the soul. So let's get down to business. Yeah, never mind. I put a pointer here. So just going again, the sacral cord is the sacral micturition center. The spinal cord goes to the leads tracts go up to the pontine micturition center, and suprapontine centers give more control to the bladder or voluntary micturition. And this is where, if you have a fracture of the spine, all of this is affected. So I will try to take you through the anatomy and physiology of normal voiding, evaluation of the neurogenic bladder by clinics, by imaging, and by uroflowmetry and urodynamic studies, and take you through some treatment issues and some case discussions. Now, for practical purposes, consider the bladder, which we all know the muscle of the bladder is the detrusor, but the ureters open here into the trigone. And the muscle, and this detrusor muscle, this is in parasympathetic control, whereas the smooth muscle of the trigone, the bladder neck, and the smooth muscle called the lysosphincter, this is under sympathetic control. Whereas the external sphincter, the rhabdosphincter, is the periurethral, it's the striated muscle, and this is under somatic control. Now, what does the word detrusor mean? Detrusor means it comes from the word expel. In Latin, it means detrusere, expel. And really, the function of the bladder depends on the contractile behavior of the muscle strips, the contractile behavior of the whole bladder, and the elastic or the viscoelastic behavior of the bladder, which gives it the necessary compliance to store. Now, have you ever wondered that in a 24-hour period, 98% of the time, you are actually storing urine in the bladder? The function of the bladder is low pressure storage with continence. We empty our bladder only when it's socially acceptable. And this is the, and we are probably voiding, if a man voids about 8 times in 24 hours and each voiding episode takes about 45 seconds, then actually you can imagine that the bladder is contracting only about 4 or 5 minutes in a day, whereas it's relaxing most of the time. So really the micturition cycle means detrusor relaxation, urethral contraction, detrusor pressure is low and the urethral pressure is high. In voiding, the detrusor contracts and the urethra relaxes. There is a high detrusor pressure and a low urethral pressure. And just a little recap of the innervation. The innervation is sympathetic and somatic. The external sphincter is controlled by the Onuf's nucleus in the sacral 2, 3, 4 segments, ventral horn, and it's a somatic system, and it's innervated by the pudendal nerve. Whereas the pelvic nerves, the parasympathetic outflow comes from the sacral outflow, and it carries both afferents and deferents from the detrusor muscle. The sympathetic outflow comes to the hypogastric nerves to the bladder and supplies the area of the bladder neck. And also, there are also sympathetic receptors on the bladder, which we have now brought to clinical use. There is whereas anticholinergics are commonly used to relax the bladder when it's overactive. These days, the beta-3 adrenoceptor receptors are in the dome of the bladder, and if we stimulate them, the bladder relaxes, and a drug is now available, which controls, which works as a beta-3 adrenoceptor agonist. And we know that this complex pathway, during the storage phase, there is afferent reflexes. These reflex systems keeps the bladder in a low pressure with the sphincters shut off. When it's convenient to void, the frontal lobe through the periaqueductal gray, through the pontine micturition center, sends the requisite symptoms so that the detrusor contracts, the sphincter relaxes. Once the detrusor is activated, there is calcium influx. Muscarinic M3 receptors are activated. There's calcium influx, and there's a parallel rho kinase systems. And these are the pathways mediating activation of the contractile system of the detrusor. So, so this is done to the M2 and the M3 muscarinic acid receptors. And the beta-3 adrenergic receptors actually relax the detrusor muscle. So, to summarize, the parasympathetic nervous system is the excitatory input. The preganglionic cell bodies lie in the intermediolateral columns of the sacral 2, 3, 4 segments of the spinal cord. They synapse in the pelvic ganglia. Short postganglionic fibers reach the detrusor, and there are significant synapses in the detrusor wall. It is important to note here that a chorda equina lesion will rather decentralize but not completely denervate the bladder, because there are neurons in the pelvic plexus and in the detrusor wall. The sympathetic outflow is from the intermediolateral column of the D11 to L2, and they travel by the sympathetic chain, the inferior mesenteric ganglia, hypogastric nerves, pelvic ganglia, and reach the trigone and bladder neck. And these are inhibitory to the detrusor. And the somatic nervous system I have just mentioned, it supplies the cholinergic neurons to the striated external sphincter via the pudendal nerves. So the sacral plexus is balanced by suprasacral influences. When we are in the storage phase, that most of the time, there are low levels of afferent activity from the pelvic nerves going to the sacral micturition center. And there, one very primitive reflex is happening. It's one of the oldest reflexes in mammals. It's called the guarding reflex. There is increased activity in the pudendal neurons which innervate the rhabdosphincter. This is the guarding reflex. In addition to that, there is a bladder afferent reflex, and this is mediated through sympathetic and parasympathetic spinal pathways. So again, I will say that the micturition reflex pathway involves bladder afferent excitation, detrusor muscle contraction, and volitional voiding is unique and acquired, resulting from supraspinal inputs. It is important to understand that the pelvic nerve afferents are myelinated A delta axons. They sense bladder fullness and tension. They are located in the bladder's submucosa and they are active in the normal bladder. But when you have a spinal cord transection, or when you have a severe infection in the urine, or an inflammatory process in the bladder, the unmyelinated C axons work, and they also sense bladder fullness and wall tension, and a new sacral reflex arc is set up. And the drug therapy, the drug development will be in the area of the unmyelinated C axons. So these are the C afferents which are active in neurogenic detrusor overactivity. So coming to neurophysiology, these are mainly the muscarinic mechanisms are in the postganglionic parasympathetic nerves, acetylcholine-mediated muscarinic receptor activations. There are 5 types of muscarinic receptors. The M2 is the commonest in the bladder, and the M3 receptors are most active for detrusor contraction. The other receptors are present in the brain, in the salivary cord, in the bowel, and such like. Important in drug development, which I'll come to later. In addition, there are adrenergic mechanisms. Noradrenaline is the primary sympathetic neurotransmitter, and alpha adrenoceptor, the alpha adrenoceptors mediate contraction of the bladder neck and the urethral smooth muscle. And there is also, I've already mentioned, the beta adrenoceptor mediated detrusor relaxation. In addition, there are non-adrenergic, non-cholinergic mechanisms, the purinergic mechanisms, which are active in pathological conditions. And nitric oxide is a transmitter involved in the relaxation of the urethral smooth muscle during micturition. So the bladder fills with urine, it stays compliant, and this is due to the viscoelastic properties of the bladder neck and the reduction of the basal contractile tone. And this, I just mentioned that there are various inhibitory influences coming down from the bulbospinal pathway, and there are additional gating mechanisms in the parasympathetic ganglia. When the bladder wall is stretched, the afferents go to the dorsal horn of the sacral spinal cord. These are called Gertz nuclei. They project to the periaqueductal ray and the pontine micturition center. The PAG and the limbic system and the frontal cortex influence the pontine micturition center, bringing the spinobulbar spinal reflex under volitional control. So the initiation of micturition is a coordinated reflex activity leading to relaxation of the external sphincter and detrusor contraction. When micturition is terminated, we switch back to the storage mode. The excitatory detrusor contraction is purely cholinergic, M3 in the normal bladder, M2 in the neurogenic bladder. And the external sphincter bladder neck area are relaxed by nitric oxide release from postganglionic neurons. So where does this leave us sort of clinically? The sort of practice that we face day to day in neurology involves lesions in the brain. Predominantly, they cause detrusor overactivity. Lesions in the spine, they cause detrusor overactivity and detrusor sphincter dyssynergia. Detrusor contracts, but the sphincter doesn't relax. And lesions of the chorda equina will cause areflexia and impaired contractility. And to enumerate these conditions, let's leave the brain conditions apart. You know that there will be cerebral conditions, stroke and head injury and other things, Parkinson's disease, Gregor syndrome and such like. But for interest today, for the spine surgeon, suprasacral spinal cord conditions are commonly what at least I see most in my practice is cervical and lumbar spondylosis with myelopathy. We see a lot of chorda equina syndrome caused by intravertebral disc problems. Of course, we see spinal injuries, But as a urologist interested in neurourology, unless you are working in a spine unit dealing with trauma, you will not gain a lot of experience in the real neurological issues. And of course, we see a lot of spinal dystrophism if you're involved with a busy pediatric unit, which I have been. And of course, there's the association of sacral agenesis with anorectal anomalies. And so these are the sources of referral to the usual neurologist. So let's now go into some very defined pathophysiological aspects. If there is a suprapontine lesion, you will get neurogenic blood vessel overactivity, like in stroke or other problems. Urinary retention is not very common, and there is no association with PSD or sphincter dyssynergia. There is a low pressure bladder emptying with coordinated voiding with intact brainstem and spinal cord reflexes. So the problem is mainly of urgency, frequency, incontinence, and rarely retention. There may be lack of awareness of bladder fillings, which I told you, the emotional aspects of bladder control, sensory inattention, and lack of the social context of micturition. It's important to understand these because there's a lot of overlap in clinical practice, because many of our patients are very elderly and they will have mixed problems. So this is what actually comes to you. Myself, supraconal spinal cord injury, trauma, cervical spondylosis, prolapsed intervertebral disc, multiple sclerosis, transverse myelitis, tumors, vascular disease, and spinal abscesses. Perhaps the most important thing is important way to understand how the neural system works is to study a patient who suffered cord transection. So initially there is a stage of spinal shock where there's a loss of reflex activity below D4, flaccid paralysis, loss of sensation, sympathetic paralysis, hypotension, and penile engorgement, parasympathetic paralysis, urinary retention, ileus, and constipation. Spinal shock recovers over 4 weeks and reflex activity returns. The normal spinal cord function above T4 and the distal cord, distal to the transection, is autonomous. There is increased striated muscle tone, reflexive spasm, complete sensory loss, and uninhibited sympathetic nervous system activities, so-called autonomic dysreflexia. Now, I think this is something which all of us have to be aware of. A noxious stimulus, a painful stimulus to the distal autonomous cord, either conditions above D6 with severe hypertension, bradycardia, headache, facial flushing, and can be a life-threatening condition. The treatment is, of course, immediate attention, removal of the stimulus, and critical care management with antihypertensives and other interventions. Eventually, bowel reflexes return and some patients have obstructed defecation. Penile erection often returns, but ejaculation is often lost in injuries below D11. The conus and cauda equina injury, I've come to see that in the usual city practice, not in a specialist center, is quite a common thing. Either you get men who've had a fall from a height and have fractured their lumbar 1 vertebra, or patients who've had a disc prolapse, a central disc prolapse. And these are something which I've seen a lot courtesy neurosurgeons and spine surgeons. associated with sensory loss, reduced anal tone, and areflexic detrusor, reduced compliance of the bladder with upper tract risks, a flaccid distal striated sphincter, and a very, very important thing I should like to point out is this is a non-relaxing urethral sphincter obstruction. This is often an associated of a conus lesion, a lower motor neuron lesion, but there is a static distal sphincter obstruction. And this combined with poor bladder compliance, because the bladder never works normal in these lower motor neuron bladders, they don't work normally. And that can be very damaging to the upper tracts. So even though maybe in your city practice, you will see a lot of this, and most of these are low pressure, safe bladders managed either by voiding naturally or by straining or by intermittent catheterization, there will be certain patients who will have this non-relaxing urethral sphincter obstruction, which is very damaging to the upper tracts. It's also associated with impotence and lack of reflex ejaculation. So let's move to spinal dystrophism. And we all know that it's maldevelopment of various ectodermal, mesodermal, and neuroectodermal tissues. And the deficit depends on the neural structure affected. And the lower urinary tract dysfunction may be, commonly it is areflexia. It's a low motor neuron bladder with poor compliance. The bladder neck is classically open. That is, it is incontinent. Patients are wet, but still, because the external sphincter may be damaged, they are in danger of renal damage. Early urodynamics evaluation is required, and elevated intravesical storage pressure requires an early drainage procedure. And this is something we must all be aware of. The other common thing which comes to us is the tethered cord syndrome. And you're obviously familiar with this. And for us, it's a very worrisome thing, particularly associated with the growth spurts at adolescence. And of either detected de novo or with a past history of dystrophism repair, and may be associated with the untreated or unrecognized lipoma, lipoma or adhesions after repair. And the spinal cord is presents, the early presentation is with a spastic gait, bowel and bladder dysfunction. And I think you tell me better, but that they respond to surgery. Maybe the motor weakness does not deteriorate. The bladder is often a persistent problem. In fact, in my limited experience, these are not very common conditions, but detethering does not necessarily restore bladder function, and that can be a devastating impact on the family, both the child and the parents. The clinical presentation is usually urgency with urgent continence, and even though the books say that detrusor overactivity is the commonest, in my experience, it is an underactive detrusor is what I've found more commonly in patients with the tethered cord. But of course, these are much, much larger experiences. The other important thing is sacral agenesis, and having worked in a pediatric unit for a long time, anorectal malformations are commonly associated with sacral agenesis. And a very alert pediatric physician or surgeon may often recognize that there is an asymmetry of the gluteal folds, or flattening of the buttocks, and this may be associated with neurogenic lower urinary tract dysfunction. Here, my experience studies that majority present with detrusor overactivity with or without DESD, and a large number can also come with areflexia. So again, it has to be recognized, treated, and it's one of the few things which can be very simply diagnosed with a simple X-ray of the lumbosacral spine. So in the spinal cord injured patient, or any patients with a spinal abnormality leading to bladder dysfunction, never treat it symptomatically. Do not base treatment just on supposition. And the one thing we have to remember that the enemy of the upper tracts is a sustained elevation of intravesical pressure, which happens if you have detrusor hyperreflex external sphincter dyssynergia. And that may happen very rapidly and it may destroy the patient's kidneys. What I think spine surgeons see a lot more in this with the city population of elderly aging city population is intervertebral disc disease, and which I've already mentioned several times, that usually there may be acute compression of sacral roots with areflexia. This again is in a younger age group and can again have devastating consequences. And we also see a lot of intervertebral disc disease in very elderly patients with cervical spondylotic myelopathy. And the most big problem is that these are elderly people who have multiple problems. This man may well have a dilated ventricles. This man may well have an enlarged prostate. He may have prostate cancer. So there are many overlaps when an elderly patient with cervical spondylotic myelopathy presents with bladder dysfunction. And one has to be very judicious in assessing these patients. And I will draw your attention to this very nice thing. If you look at neurogenic bladder by the spinal cord level, and hyperreflexia is marked with these dashed things. The black ones are the dyssynergic bladders. And you will see as the lesion in the spine, as you go down from cervical, thoracic, lumbar to sacral, the sacral, the incidence of areflexia increases and the incidence of hyperreflexia diminishes. And dyssynergia is likewise common in higher injuries, in cervical and thoracic injuries. Likewise, in the specific paper for disc disease, you can see that as you go down from the cervical to the lumbar levels, that the detrusor areflexia is commoner. If you go to the books, you will probably find hundreds of many, not hundreds, but certainly many ways where neurologists have tried to classify the neuropathic bladder. The simplest way is this, and this is now widely accepted as the Madersbacher classification of the neuropathic bladder. And you look at the sphincter, and it's a functional classification. On the basis of your clinical examination, on the basis of your neurological examination, you identify the defect in the urethral sphincter, in the detrusor, and if the lesion is in the spinal, and there's can be various combinations of overactivity with underactivity. So with a spinal lesion, it may be overactive bladder with an overactive sphincter. With a subsacral lesion, it may be underactive bladder with an underactive sphincter, and various permutations and combinations. And that's exactly how we as urologists try to manage a patient, try to understand whether the detrusor is underactive or hyperactive, whether the sphincter is underactive or hyperactive. So let's, the clinical, the clinical assessment, there has to be a focused uroneurological examination. We look at, as urologists, we look at the peridial sensations, we look at the anal tone, and we look at the bulbocavernosus reflexes. We evaluate we have already evaluated the symptoms and investigations as appropriate. Usual urological investigations include blood profiles, urine bacteriology, X-rays, ultrasound, if necessary, CT scans, renograms, and other investigations. But I think the most important is to come to a diagnosis of the functional problem. And we urologists have a guru, and that is a man called Richard Turner Warwick, who actually has made immense contributions. A British surgeon, a urologist, who made immense contributions to urology in various fields. And urodynamics he was one of the early people to publish on urodynamics, do proper controlled studies with urodynamics. The bladder is an unreliable witness. The bladder, patients do not complain of symptoms which are disease specific. The patient cannot report symptoms properly. the clinicians can listen to the history. I did mention that with a lot of experience, you can understand the urodynamic problem. But looking at the bladder, say on an ultrasound image or at cystoscopy, in those days in the 1970s, cystoscopy was the standard tool for assessing bladder dysfunction. So there's nothing, if you look inside the bladder, you really don't know how it works. And maybe Indrajit can tell us that who was the orthopedic surgeon who actually did this work in 1966 in SSK. In 1966 in SSKM Hospital, bladder dysfunction was studied in spinal cord lesions, and I salute Birendra Kumar, someone, and I managed to locate this in a library amongst old books. And in those days, cystometry was performed, a single channel cystometry, where they put tubes in the bladder, and they put, you can, even with limited resources, you can still do these things to assess the bladder function. If you're in a desert island or in a village or somewhere, you can do what is known as eyeball urodynamics. You can measure the bladder pressure. No, I don't know. He was an orthopedic surgeon, not a urologist, and not done by the urologist of the time. His guide were not the urologists; they were the orthopedic surgeons. So there are limitations of doing a single channel urodynamics, and you may all have sort of a lot of misconceptions about urodynamics, about how it is. The essential thing is that the bladder is an intra-abdominal organ, and if you measure simple pressures in the bladder, it will not be correct, because there's also the issue of intra-abdominal pressure. So in multi-channel urodynamics, you place a rectal catheter and the urethral catheter, and you subtract the P vest, which is the total pressure, from the P abdomen, which is the rectal pressure, and you get the true detrusor pressure. So this is the fundamental and very simple thing that all urologists want to know. And if you can measure this very carefully with the aid of this multi-channel urodynamic systems, where there's a probe in the bladder, there's a probe in the rectum, and you can measure the flow rate, and you get the cycle pressure, you get the abdominal pressure, and then you subtract and you get the true detrusor pressure as the patient passes urine, and that's the flow rate. So this is a normal sort of a cystometrogram. And this is all that multi-channel urodynamics is about. A final channel is a EMG probe, and with advanced, previously needle electrodes were used, and these days we use surface EMG electrodes, and you can very easily do these tests. And just for your knowledge, the infant will have a reflex void. After the bladder fills to say 150 or so, he will void. Whereas the adult, a normal adult, the bladder will fill up to 300 or 400, and when he goes to the toilet, the detrusor will contract, and he will pass urine. And the EMG signals will stop when you pass urine. So this sort of, this is what I told you about the micturition cycle. When you're voiding, the pelvic muscle, the urethra, they all relax, so there's less EMG activity, the detrusor contraction is here. Whereas in the paraplegic man with a high spinal cord injury, the bladder will be unstable, there will be some unstable contractions, and when the bladder contracts to pass urine, the EMG channel will show contractions. So this is called bladder sphincter synergia. And if you do simultaneous radiology, you can get video urodynamics. So I'll just rush through this and show you some typical curves. This is the typical normal uroflow, a bell-shaped curve, and this is the typical bell-shaped curve. Now, when the patient has a prostatic obstruction, the flow is low, but it's a flat flow. This is the flow which you can see in neurological patients where it's fluctuating. See these intermittent flow, continuous fluctuating flow. These are indicators of, this one is an indicator of a weak detrusor, and this one is an indication of maybe an areflexic detrusor, voiding by straining. So what do we do in urodynamics? We measure the cystometric capacity when the patient has a strong urge to pass urine. We also measure the compliance of the bladder. This is the relation between the change in bladder volume and change in detrusor blood pressure. Now, this is fundamental to neurogenic bladders, because in a neurogenic bladder, the systometric capacity may be reduced, but very important is that the compliance is affected. And because of the lack of the normal reflex activity of the bladder, the pressures will rise very high. And any detrusor pressure, more than 40 centimeters of water, will cause high damage to the upper tracts. So in a patient with normal bladder compliance, the red line, there is as the bladder fills, there is just an acceptable little rise in detrusor pressure. So, but if you have any significant rise, you can get what is known as detrusor overactivity. I'll explain to you the difference between overactivity and compliance on the urodynamic traces. There are several types of detrusor overactivity. A phasic detrusor overactivity, where a spike on bladder filling. So that is what you get either idiopathic or neurogenic. You can get terminal detrusor overactivity. That can happen in obstruction. And you can also get neurogenic detrusor overactivity and idiopathic detrusor overactivity where there's no cause. So these are the various times. In very elderly patients, you can get detrusor hyperactivity with impaired contractility. These are the various terminologies. And I'll just show you some quickly. So filling phase, red line detrusor contractions, these are called phasic detrusor overactivity. This is also a form of detrusor overactivity where you get unstable contractions. Another detrusor overactivity where during filling there is a little leak. Sometimes a cuff, these are cuffs where abdominal pressure and vesical pressure rises but the detrusor pressure is flat. That can provoke a detrusor overactivity. And you can often get terminal detrusor overactivity, which may be a manifestation of either of bladder outlet obstruction, say from an enlarged prostate, or even from neurogenic causes. And this is what you will see in a man with very severe detrusor overactivity with leak. You often will see this sort of a curve in patients with multiple sclerosis and urinary incontinence. So these are just, so it's very easy. Even if you're not urologists, but if you're given a trace, you can at least try to understand. Look at the P deck. How do you understand this is a good trace? That the patient coughs, these are the spikes, abdominal pressure rises, vesical pressure rises, and this stays flat. So the machine is working all right. And in this one, the detrusor pressure is rising, the vesical pressure is rising, but the abdominal pressure is not rising. So that means that this is primary detrusor overactivity. Now, as neurologists and spine surgeons, you must know this definition, the bladder leak point pressure. This is the intravesical pressure where a catheterized patient will leak around the catheter. So, and this pressure is very important because if this pressure is high, which I've already mentioned, 40 centimeters of water, the bladder become very tense and it'll sort of, the pressure will go to the kidneys. So this is something you need to be aware of, and typically occurs in patients with detrusor sphincter dyssynergia. And this is the sort of seizure. If you do synchronous video urodynamics, you will see that with the rise in detrusor pressure, the sphincter is shut down. This is the bladder neck. The bladder neck is open. The sphincter is shut down. Detrusor pressure is sky high, and within a few weeks, it will start to reflux into the kidneys and damage his kidneys. So, so these are another slide of detrusor sphincter dyssynergia. So this pressure is important. And if the detrusor pressures go this high, it is important. Now, you all teach your patients how to do intermittent catheterizations. Now, I don't know if there are physiotherapists here who are training people, but this is why knowing the detrusor leak point pressure is very important when you teach someone to do self-catheterization. If the bladder residual, by and large, if the bladder residual goes above 400 or 300, detrusor pressures rise. So it's very important to not just tell the patient that go pass the catheter, he's learned how to and that's the end of story. You have to ask the patient to keep a bladder diary so that you can record how much he's coming out when he's passing the catheter. And look at this man. He's got a neuropathic bladder. Pressure at 460 is 40, just acceptable maybe. So we must, even if he's on intermittent self-catheterization, the self-catheterization frequencies must be such that, maybe at 200 or 250, you pass a catheter and empty the bladder. Alternatively, you'll have to reduce the bladder pressures. And how do you reduce the bladder pressure? With either drugs or botulinum toxin injections or enlarging the bladder by various surgical means. But if the patient is poorly compliant, then আমি সকালে catheter করি, রাত্রিরে করি, আর কি হচ্ছে আমরা জানি না, so that can kill his kidney. Also, you will see that very conscientious doctors will actually insist that some patients have a indwelling catheter at night, because at night, 8 hours, it is often not possible to wake up and you've got to instruct the patient. Either or carer has to be instructed that pass a catheter at midnight and 3 o'clock in the morning or 4 o'clock in the morning to empty the bladder. So without a proper bladder diary, like to manage this sort of patient, you really do not need a urodynamic testing. You can even just keep a frequency volume chart that how much the residuals are, and you know what is happening, and you follow the patient with an ultrasound. You don't even need see whether the upper tracts are dilating or not. So this is very, very important for spinal surgeons. These are not much of a problem. The chordicina, I told you, it's a contractile bladder, usually low pressure unless there's a distal sphincter obstruction. And areflexic bladders are usually safe. So the objective of treatment is basically one, upper tract preservation. All the others are secondary: prevention of UTI, storage, leakage, social acceptability, etc., etc. And there must be some lifestyle interventions. How much water, large, because these patients, the systems become colonized with bacteria. Neurogenic bladders, they carry bacteria. Asymptomatic bacteriuria is common. That does not need treatment, but a high fluid turnover is important. High fiber diet to keep the bowels clean, because as you know, all infection in the urinary tract is ascending from the colon. Good quality pads, portable urinals, these have to be provided. And we'll come to catheter drainage later, and then there's pharmacotherapy, surgery, and other forms of treatment. So once we've identified what the problem is, whether it's a storage failure or an emptying failure, whether it's a detrusor failure or a sphincter failure, then we can treat it. So that's the way to address these problems. So the detrusor cause may be overactivity or loss of compliance, detrusor cause may be underactivity, etc., etc. So we do it. Like if the detrusor causes overactivity, the treatment is anticholinergic agents and botulinum toxin injections. If the sphincter causes incompetent sphincter, there is no drug treatment, but there are some surgical treatments. If you cannot empty, if the bladder is not emptying and the detrusor is underactive, methanacol is the only drug available. If the sphincter is causing an obstruction, then you can give, even though it's not level 1 evidence that botulinum toxin can be injected into the external sphincter. So regarding drugs, I told you the role of drugs is to reduce the detrusor pressure, increase the holding capacity, and it's often an adjunct to intermittent catheterization. What we want is we don't want side effects. What are the side effects? Muscarinic side effects, as you know, M1 is in the brain. One important thing you must remember that we write so many drugs like oxybutynin, we write sulfenacin, this and that. All of them, many of them cross the blood-brain barrier and can cause cognitive dysfunction. And that is real. Cognitive dysfunction is real. So when you don't write these drugs right and left without considering the fact that the patient may have cognitive dysfunction. Because many of these receptors are in the brain, and I think so. We don't want any interference with normal or higher efficacy, etc., etc. And there are many anticholinergics. Obviously, a selective muscarinic activity. So M2 and M3 antagonists will be the most useful from what I've just told you. Advantages of M3 receptor selectivity: maintained efficacy, less cognitive effects, no effects on heart rate, less severe dry mouth. So these are the various agents used. Now, recently, I told you the beta-3 agonists are used, and this is available as mirabegron. Not much data on neuropathic bladders, Probably the best anticholinergic agent in practice is the musculotropic relaxant, oxybutynin hydrochloride. Uh, common name is tropan or Sistron. And this is very effective in neuropathic bladder. So this is my drug of choice when I'm using for patients with serious neurological dysfunction with high diffuser pressures. And the other drugs can be used. The best thing about darifenacin as a product is that it does not cross the blood-brain barrier. So recommended in very elderly patients. The same thing with trospium. It doesn't cross the blood-brain barrier. And there are various adjunct treatment. You can use desmopressin, which is a antidiuretic hormone, and that can reduce urinary frequency at times of stress, but can cause hyponatremia, cannot be used in elderly people. A lot of problems. So they are there, but PDE5 inhibitors, sildenafil group of drugs, they work by relaxing the outlet and relaxing the smooth muscle and increasing the blood circulation to the pelvic organs. It's useful for erectile dysfunction. It's also useful for bladder dysfunction. You can add to the mixture of medications. May also help sexual dysfunction in patients who have such a problem. Detrusor underactivity, there are some cholinergic drugs. They only work, the commonly used drug is something called bethanechol. It works only if the bladder already has some contraction. So, and then, of course, the drugs that we use for the prostate, the alpha blockers can be used to relax the outlet and can also be used for autonomic dysreflexia prophylaxis. So I think we are going forwards. Apart from drug therapy, you have to empty the bladder if it's not emptying completely. And it can be intermittent catheterization. It can be a tube drainage, catheter drainage. And there can be various forms of surgery, like sphincterotomy, that is in a dyssynergic sphincter. You can cut the external sphincter, and then you can divert the urine or use various prostheses like sacral stimulation and such like. So I'll just have a little word about catheterization, detrusor underactivity. Catheterization can be either indwelling or intermittent. Intermittent catheter may be sterile versus clean versus aseptic, even though original Gutmann's rehabilitation system in the Second World War, at that time, they were doing aseptic catheterization. In practice, it is now accepted that intermittent self or third-party clean catheterization is accepted, even though in Europe, there were some of the guidelines were saying in the last decade, last 10 years, that go back to very sterile techniques of catheterization. Frequency must be 4 to 6 times a day. Catheter size must be 12 to 14. Residual urine must be less than 400. Maintain a bladder diet. And it is well accepted that indwelling catheters, silicone catheters should be used. There is a high incidence of latex allergy in neuropathic patients. I'm not sure of the science behind it. Actually, there's no good explanation, but neurological patients do not tolerate long-term latex catheters. High incidence of allergy. So use a silicone catheter. This is almost level 1 evidence now. So don't use latex catheters for long-term use. And suprapubic catheter has certain advantages. Intermittent catheterization is still preferred whenever possible, but ensure that the drainage is low pressure. Now, it can be difficult if there's a stricture or a false passage, if there are severe infections and similar things. Indwelling catheterization has its own risks. Whilst it's simple and easy to manage, chronic infection, stone formation, tissue erosion, you can get traumatic hypospadias. The urethra can be devastated. Bladder neck urethral destruction, bladder wall fibrosis, and of course, bladder cancer. So avoid indwelling catheterization unless it's as a last resort. External appliances, condom catheter can be used in conjunction with external sphincterotomy. Say if you've done a dyssynergic external sphincter and all other CIC and everything has failed, then you make an incision endoscopically in the external sphincter. It's quite a morbid and difficult operation. This is the muscle we try to preserve when we do prostate surgery. But when you try to cut it for a sphincterotomy, it's tough because you don't know how much to cut, how deep to cut. It can cause a lot of bleeding, and it may have to be repeated because the entire sphincter is not damaged. So some people have used for sphincterotomy, instead of using doing a sphincterotomy, you can place a stent. But there are problems of stents also. Various forms of surgery. detrusor myomectomy is an operation where basically you remove the detrusor on the dome of the bladder, the mucosa bulges out. That reduces the pressure in the neuropathic bladder. I haven't done it, and it's not a very popular operation. What is certainly doable, which we've done quite a lot of, is an augmentation cystoplasty, where if all else has failed and the patient is suitably motivated, you put an intestinal patch on the bladder, which is called a cystoplasty, that will automatically reduce that leak point pressure to zero. Kidneys will be safe, but the patient will be dependent on self-catheterization. So that is augmentation cystoplasty. And you all know the consequences of putting bowel onto the bladder. So there is a risks of metabolic risks and cancer risks. Metabolic risks are of acidosis and bone health. So various small and large bowel can be used, and this is how it is done. And if we have time, we can discuss certain things. And you can also do certain various forms of continent. You see, there are many sort of problems in men who need neurological patients who need this sort of attention. Hand function is very important. We are, managing a cervical spine injured patient with bad hand function means how will he do self-catheterization? That's a huge problem. So, how will he take care of his catheter? If the patient is wheelchair bound and the catheter going into the perineum, pulling on the wheel of the wheelchair and cutting through all sorts of problems. So in many a times, you've got to consider options like urinary diversion, maybe create an augmented bladder and do a little stoma in the abdomen through which you can catheterize and empty the bladder. So these are various procedures, which I would love to do as a surgeon, but you need the team to do it, and maybe that Shaumajit Bas's spinal unit should provide. Go into trauma, and you'll get all sorts of cases. There are fantastic operations. Reduce pressures in the bladder by doing a chimney operation. You put a patch on the bladder, and there's a little chimney of intestine coming in, so that the patient passes urine, whatever he doesn't pass from below, the bladder pressure stays low and it's collected in little pouch here. So this is called an ileovesicostomy. And the last resort is whether the lower urinary tract is devastated in a bed-bound patient. You may have no choice but to do a ileal conduit diversion. These are not good operations, because whenever urine comes in touch with bowel, you get acid load in the body. So chronic acidosis. So these are all things we've already discussed. I wanted to tell you that this, in an underactive detrusor, third-party bladder expression is not good, which is called the Creedy maneuver or Valsalva. Many patients with lower motor neuron, these patients which you are operating every day with a lumbar spine problem, lower motor neuron bladder, there are many of them avoiding by abdominal straining, and they come to urologists. We are happy that they're avoiding, but they end up with all sorts of problems, hernias, and mainly rectal prolapse and all sorts of other problems and problems. So it is judicious that even the surgeon or the neurologist actually guides them to use self-catheterization to empty the bladder. Triggered reflex voiding, frankly, unless you're working in a spinal injury patient, you don't really see these patients, Sometimes tapping the suprapubic region or the groin will start a contraction and empty the bladder. And of course, there are other forms of treatment, including various forms of electrical stimulation, which actually fascinates the doctor who's interested in it. But we have certain limitations in our practice. But all these forms of treatment, this electrical stimulation, the fascinating thing is that acupuncture is a form of percutaneous nerve stimulation. Acupuncture. One of my chiefs actually used acupuncture. He did a paper in 1987 in acupuncture in the knee, the posterior tibial nerve, and in the ankle, and that could actually reduce bladder frequency. It's conceptually brilliant, and this has actually got the posterior tibial nerve stimulation for overactive bladder muscle overactivity is now in the guidelines. You can use it, but it's a very expensive device, and we couldn't use it. And so various things you can do, at least in an area where, as a doctor, you give the patient some hope, and these are good things. The other important thing which we can certainly do, and we are not doing enough of, are intradetrusal botulinum toxin injections. So what does botulinum toxin do? It's a very bad poison, as we all know, and it somehow it attacks the SNAP proteins in the nerve terminals and prevents acetylcholine release. And that was refined by, you'll all be happy to know, by one of your batchmates in medical college in Kolkata, Prokar Das Gupta, my contemporary. And he was the person who published first on this, along with, of course, the senior author was a very famous neurourologist called Claire Fowler, who worked in Queen Square. So botulinum toxin is something which is doable. It has got, I don't know why it has not worked. You see, 2005 onwards, we did a few. Then when the published trial, we used it off-label. A lot of people were using off-label, but when the trials came out, then it became legitimate to use it, or guidelines were saying use it, the doses were refined. There came a lot of publications that Botox causing respiratory depression, and a lot of little bad press, and also the effect does not last long, 6 months, 9 months. Somehow, but despite personal interest in this area, it has not met viability, economic viability. Each injection, 300 units in a neuropathic bladder will be around, the injection will cost 35,000. So each treatment, which lasts only 6 months, will cost you about 50 or 60,000, depending on what the costs of a cystoscopy are. And then in the private sector, it is so much counseling. And if you tell them that the Botox still carries a black box label that if wrongly injected and it goes into the circulation, it can cause respiratory depression. It's a big job to counsel patients. So they haven't been able to sell the product in India. So basically, this is how you do it. 200 or 300 units, it's injected into several places in the bladder. There's nothing new about Botox. In the late 80s, we had, when we were training, then we were told about a system called phenolization. We were injecting phenol into the subtrigonal area. So this is it. So you choose 30 spots in the bladder and you give the injection. So I think I should stop there. There's no end to what you can talk about. I think we can do a lot of things for these patients, and these are sacral rhizotomies, sacral deafferentization, and these are not things which, unless you guys actually pick up cases and develop spine units, these will not come to urologists. Sacral anterior root stimulation, sacral neuromodulation, these are all possible for certain selected cases of neuropathic bladder. Now, what we all urologists want is something to treat the underactive bladder, which doesn't contract. Say a young man has had a central disc prolapse and he's lost his bladder function. You see, we can bring back the sexual function by giving injections in the penis and that sort of thing. But the bladder function is there. So there you can do certain things like bladder covering by striated muscle. You can, that some people have done, I don't know, can work. And a lot of other new things. And then there's something called, which you will know, that there is some procedure there transplanting the L4 or 5 ventral root to S2 ventral root in China, and all sorts of things. But one thing which is very interesting and is that this afferent directed agents, all the treatment were on the efferents. So some treatment directed to the afferent has not been developed yet. So these are the things for the future. And the other thing for the future is, I don't know which you can educate me. There's something called rehabilitation for spinal cord injury, regeneration of the spinal cord. Some antibodies are no-go antibodies are being used. So I don't know. So that's all. Thank you very much. Now, I think, Shomujit, you should present your case. Yeah. I've got some, we've got some cases, but I think you discuss your case. I think that's the most important thing.
So starting off with your case, you should show the case together. Before that, let's
Yeah.
ask the audience to interact with. I'll start off with the first thing that is in a typical clinical scenario, when we get a patient with a spine and we know that he's incontinent preoperatively. Ideally, when should we ask him to start self-catheter? We leave him on a catheter, usually. He's preoperatively catheter, or actually he's so much at a loss so far as bladder function is concerned that we do keep him on a catheter with the operating and keep the catheter and ask him to go home and then ask him to come back to his social media. So what is the ideal time for starting with this self-catheter?
I think immediately after, if you look at the, if you ever read Reginald Watson-Jones' Fracture and Joint Injuries, there's a chapter by Gutman in the 1940s. I'm lucky to have a book in my home, 1940, Second World War time edition of Watson-Jones' Fracture. There's a chapter by Gutman on rehabilitation. They were doing it then, actually. All spinal injured patients would have, so I don't see why you can't do it straight away. If I think the real limitation, Shumajit, is that we are not counseling our patients about bladder dysfunction when they're coming for this sort of surgery. That is what delays from my side. You know, I have to, if you refer the patient to me after the spine surgery, and then there's a little period of time for the patient to accept that. So I think if possible, preoperative urodynamics, just for the, I know it is not necessary, but it is something patients want to understand what their problem is. So maybe it's good documentation also that if you have pre-op urodynamics for patients who before embarking on spine surgery, it makes sense, especially for degenerative diseases.
First, you recommend that preoperative uropropectomy is done for all patients who have clinical history or clinical evidence of bladder dysfunction?
Actually, these are very simple, non-invasive tests, isn't it? It's just, I would just need a voiding diary and a free flow rate and an ultrasound for residual urine. And counsel him that, you don't have a basic urological problem and post-operatively, I think it is well within anyone's just to, you see, a lower urinary tract evaluation requires a voiding diary. Basically the same thing as an intake-output chart. If the patient is voiding 7 to 8 times a day with good 400 cc volumes, there is no leakage and there is no residual urine on ultrasound, which is part of now, I think, standard. I don't think needs a urological referral. And the flow curve is a nice bell-shaped curve. You know, we had a trainee in Park Clinic who actually did this. We did about 20 cases of urodynamics on patients with cervical myelopaths who were undergoing surgery. Now, I know that there are some considerations of logistics in the private sector. But I think in my Ramakrishna Mission government sector, in private hospital sector, you can easily do pre-op workup. You just need the manpower to do it. It doesn't have to be a urologist. And self-catheterization can be started within 24, 48 hours if the patient has been, primed about it.
One of the problems injury that they will be causing. So in that case, like, do you think it's a good idea, like, because we do not know what is exactly the bladder status, eventually how it's going to is it a diffuser, hyperlaxity, or is it going to be sphincter overactivity? We do not know which one it is eventually going to turn out. Say, for example, a patient with a knee fracture. So self-catheterization can be more mutilating actually in a patient who is having an overactive sphincter. Is that right?
I think you have to individualize things, but of course a person, and I don't know the level of nursing one can provide, because the other real fear is, as I said, to introduce an infection.
Yes, so that's true. But without knowing actually what eventually is the status of the bladder, like whether it is first or second category, like can we just keep the patient on a catheter itself? Then we are sure that the bladder status is established already, and then based on the bladder studies, we go ahead with either self-catheterization or.
I think indwelling catheter has the same share of complications as intermittent catheterization. So at the earliest, if say the patient is quadriplegic and maybe the logistics in our part of the world, I haven't seen any. Do you actually start catheterization?
Very, very sort of proactive in starting intermittent catheterization and take out intermittent catheterization. The main problem with going into a self-catheterization to discharge the pain. Most of these patients are still painful, and to teach them self-catheterization during their painful days is a big issue. So in my practice, in our image practice, what we do is we discharge the patient. They come to the first follow-up in about 3 weeks' time. And in that first follow-up, they are admitted as a day care. We take out the catheter, we do a trial of catheter removal, we take out the catheter, ask them to void, see a couple of void weeks, 3 weeks. First follow-up, they come into the first follow-up. We take out the catheter, we do a trial of catheter removal by asking them to void after drinking a lot of water, and then we do a respiratory ultrasound, and we see how much of blood is there, and as what is more than the city of bladder ultrasound, then it's wise to ask him to get a self-catheterization. But on the painful days, I mean, with an incision,
you can certainly keep an indwelling catheter for 2 weeks or 3 weeks. That's not a major issue.
If you have an indwelling catheter inside you, using a very vital chance of opportunity to assess the return of blood. When we do a self-catheterization, intermittent catheterization, you can see that by the body value, initially it was 400, possibly 100, 200, and we actively ask them to stop catheterization with less than 100. I don't know what you would say.
Yeah.
If it comes down below 100, then we say no catheterization.
Considering our scenario also social structure, whether the self-catheterization, strictly self-catheterization or intermediate catheterization by good nursing staff, because there is a chance of infection and whether the good sterility is maintained.
Exactly. That is the only limiting factor.
We have Dr. Dilip Sen online.
Dilip there.
So, Dilip, if you are, it's great to catch up with you. I mean, it's fantastic.
Yeah, sure. It was very nice talk, but I missed much of it because I was driving to the hospital and I about to start a surgery. But the glimpses that I got, it was excellent. Thank you very much, Kalyan.
Welcome. Nice to see you after so many years.
Sure.
Any other questions? Sir, I have a question. Actually, what would be the initial frequency of this CIC? Because considering the PPRD, what would be the initial frequency of CIC and what would be the time hourly in between, or is there?
As I think I mentioned that a bladder diary is absolutely essential. So the patient must be given a diary to record how much he or she is drinking and how much urine is coming out with self-catheterization and how much urine is coming out with self-voids. Because I just told you, if the residual crosses 400, then something harmful can happen. So you must ensure that the residuals are less than 400. So, and at night, I think 3 or 4 times self-catheterization is never enough. You should try for 6 times. You can compromise and say one catheterization at midnight and the other one at 5 o'clock in the morning. But there are many experts and neurologists, especially in a high-pressure bladder, you should have a indwelling catheter overnight maybe.
One more problem we are facing is that in the peripheral part of our country, we cannot afford all the time a new data. So is it cost effective to use
Yes, yes, it is allowed. You see, there, as I told you, there's a little divide on either side. In Europe, there was a trend in the last 10 years to increase the sterility thing, part of it. But in the United States, it's still accepted to have clean catheterization, which means that, which we were originally told that wash your hands, follow general hygienic measures, and after use of a catheter, you wash it in plain water and keep it in a dry place. Maybe on I tell the patients to keep them on some newspapers so that it absorbs the fluid and it's dry. So yes, I think that is accepted.
So is that the difference between clean and aseptic? Clean means that you do not have to use sterile gloves and sterile
Nothing.
catheter every time.
That's right.
Clean means that you have to have a clean hand and a clean catheter.
Yes,
That's what it is.
exactly. And if the person is doing it himself, then it should be clean. But if a carer is doing it, I would sort of insist that to follow as much sterility as possible.
Another very common problem with us is the clinical setup. Patient comes with the perfectly whiting, suppose in case of severe upper canal stenosis, he was whiting normally before surgery. Once we have done the decompression, what happens in out of 10 cases, 2 or 3 cases, patient stops, there's a sort of urinary operation. So we take off the catheter, after 24 hours, patient not able to pass it. Now there is a problem. Again, you catheterize the patient, again the patient is not able to pass it.
Well, I don't think so. I think this is usually this is sometimes they have a successful trial after 2 weeks, or they had a borderline problem pre-existing, or that's why it makes some sense to be able to counsel the patient, because many of the patients who are referred after they develop post-procedure retention, they're a bit worried actually. And they often go and seek other opinions and this and that.
Just sharing on this information, I think this same what you call a hack. This we were actually told by one of our gynecology professors back in Delhi. Most of these post-cesarean patients had a lot of urinary retention problems immediately. And as he said, the best way that we actually go ahead with making them pass urine is take them to the bathroom and open the tap. Just open the tap, and seemingly somehow it works most of the time.
So that means, so I'll ask you one final question before if anybody else has any question. Yeah, so should one question. Yeah.
In polyclinic syndrome, typically we see different variety of urinary symptoms. Some have just minor amount of perianal anesthesia, some has complete retention, some have void with difficulty. So, is there any criteria to prognosticate them before surgery? We tell them that we can take away your leg pain with the surgery. So, seeing their preoperative symptoms, can we prognosticate them that how much time it will take so that your bladder function can return or it may not return? Is there any score or something so that we can tell them preoperatively what is the chance you will have a better outcome or worse?
And that's a very good question actually. That's material for a very common problem and material to create the score yourselves, I would imagine. But in practice, actually, again, a careful pre-op assessment if the patient has pre-existing voiding function, especially in a middle-aged male with prostatic enlargement and that sort of thing. These are the patients who often
So, as a corollary to this question, should we incorporate residual polyp-mastication as a standard assessment before any surgery or spinal surgery to prognosticate whether the disease is improving or bringing an alarm bell that requires surgery, or what is the improvement what is the cutoff in males and females that you consider?
Okay. So I think, again, which I said at the very outset, that the symptoms of the patient are very important. You must, that is a good, maybe a symptom score assisted assessment of his symptoms. A residual urine frequency volume chart, that's actually something which you are all non-specialists, but in urology practice, in functional urology, the frequency volume chart or the bladder diary has a very, very important role. You don't need complex urodynamics. It's a so these are things which which you can easily implement in your practices and understand whether the patient has a real problem or not. And there are, so this is something which you can incorporate in your pre-op clerking procedure. And regarding the residual urine, remember that one single residual urine estimation is never enough. There must be at least 2 or 3 residuals to see whether they are okay or not. So I personally feel that a good history, even the old-fashioned ways of, time of passing urine, if you've done as many flow rates as I have seen, I don't actually need a flow rate. I tell the patient that you see this one contains 100 cc, 150 cc's. You measure how long it takes and keep a watch on and measure how long it takes. You don't get the peak flow, but you get the average flow. And in general, if a person empties his bladder within 30 seconds, he has no problem. So there are many ways of assessing just clinically without recourse to any other investigations, accepting a flow rate and good history. Maybe on a symptom score. Bladder, there are many scoring systems now available. And in a teaching unit like yours, I'm sure you can implement it.
So I'll ask the final couple of questions before we go to get this. First question is, as you've been taught by from medical school, that 400 mils of urine in the bladder, 40 liters of centimeters of water, separation. Those are the cutoff marks for protecting the upper urinary tracts. As you said, that the patient should use the intermittent catheterization so that this gets prevented. That means no more than 400 cc urine and no more than 40 centimeters of water related to suppression. So how would the patient understand? He has got a major sensory disturbance. He doesn't understand bladder filling. So how would he understand when to actually do what are the exact types of catheterization?
Again, by educating the patient to look at his own bladder diary. He has to increase the frequency.
At one point in time, say after dinner at 11 p.m., he does an intermittent catheter, takes 100 cc. And in the morning, say at 12 noon, he takes 400 cc. So what inference do you have from that?
He's got a very low, I don't know, either he's drinking too little or
so what exactly you see in the body that this means that you have catheterized at this point?
Well, what I would infer is that he's probably severely, if he's not passing urine naturally between the 12 o'clock and the...
Suppose he passes urine naturally 200 cc twice at 8, 10 and say 10.
Well, in that case, maybe he doesn't need to self-catheterize so often. That's where urodynamics could help you. A cystometry, if the upper tracts are not dilated and you can measure, he may have a very compliant bladder. So that's where urodynamics can help you in planning. That's okay then. He's probably okay. If he's passing urine and in between pressure, you actually need some sort of a urodynamic assessment in these patients.
The second question is, many of these elderly patients with have bladder outflow obstruction also. So in that case, what exactly, and many of these postmenopausal women have repeated UTIs also as a complicated factor to the upper urination. So how do we weed out these outliers so that we get a proper assessment of the coordinated bladder function?
I think we just treat it again. It's the same thing. For a woman, which is the easier answer, is that again ensure that the residual, she doesn't carry large residuals and she's got enough estrogen locally. estrogen creams and timed voiding and assessment of residuals, and symptomatic treatment, as we just saw, anticholinergics and similar things. And if she's got really a low flow with residual urine and repeated infection, she may simply benefit from a urethral dilatation because she's probably got a stenotic distal urethra. So for a man, again, I agree, it's very tough. You know, that's the situation where you have to maybe even do urodynamics and not operate until the patient goes into retention, near retention, or establish him on CIC. These are very difficult things. In my time, I have operated on certain patients who've had cervical spondylotic myelopathy with residual paraparesis still coming with a very large prostate and obstruction, where we've been forced to operate. And then in limited experience of a few patients, less than 5 or 3 or 4 patients maybe, I have seen that if they're really going to retention and then you operate on them, they get better, but they have a lot of frequency urgency which needs separate medication. But you have to counsel them very thoroughly before you operate on them. Exactly.
So, what I'm saying is, the patient asks, this is not blood. I have organ problems. I have my ear frequency. I have organ. So, after this surgery, what part of it might take that? Because you know you have an additional PO.
I still suggest that one should be very guarded about operating straight away. You know, not operate unless the patient goes into retention or something. You know, we have some joint patients that way actually, where yeah, prostate surgery.
After surgery, they don't improve on that, possibly because they have very good data.
One of the big
One of the big ultrasound shows the vestibular and the size of the prostate is always not correlating with the function of, I mean, with the amount of.
I find this to be the biggest pitfall, what you are saying. In my day-to-day city practice, you know, I will no way say that I'm in a specialist unit. In a general practice, you know, I myself have operated on patients with who I thought had clear-cut bladder outlet obstruction, and then he was incontinent. And 5 years, 3 or 4 years later, you know, a year later, he was still incontinent. And then I had missed a border equine. So now, you know, I have my threshold for, I don't wait to refer to a neurologist for an MRI of the spine. But I think, you know, I have sufficient experience of this to order an MRI straight away. Very difficult.
Is it possible that in these patients, you start them on drugs? Can it be a therapeutic trial of drugs?
Yes.
And that gives a lot of relief, particularly from the frequency of the urgency. The frequency of the urgency would improve if it's not a real obstruction there. I think that would perhaps be a help.
That is okay, but if you've got to do cervical spine decompression, go ahead and do it. Or if you've got to do a lumbar spine decompression, go ahead and do it. These are more important. Walking and stability of walking is more important than the bladder. I will just say, bladder is not as important organ. You can work around the bladder, but you can't, the patient can't walk easily in the mass section.
Plus, they're paranoid about bladder problems.
So
you can show us the case and then.
Okay. Okay. I don't know. In that case, I'll just share my screen again.
The other neurological function, even if it improves, they will insist why it's done.
This is not improving, this is what we do.
So this is our common patient who we encountered about 15, 20 years back, 2008. কোথায় গেল? কি হচ্ছে বলতো? So this is this male young adult. He was 20 years old in 2008, and he presented with sudden onset weakness of both lower limbs and retention without a history of trauma. And on admission was found to have classic paraplegia with sensory level of L1. Motor power of both lower limbs, grade 0/5, absent jerks, planters were unresponsive, and complete loss of sensation below L1. So there was no local tenderness over the spine, and the range of movement could not be tested due to pain. There was a small sacral sore. So this was managed by Dr. Shomojit Basu, and he had a large MRI done, which showed some bleeding in the hematoma, which Shomojit can tell us exactly what. This was the lesion. So,
it was actually an extradural AVM which bled.
Okay. So that Shomojit knows the hematoma was extruded. Diagnosis was a spontaneous epidural hematoma. Yeah. So 5 months down the line, this is Dr. Basu's note that he is now reasonably continent and does not require CIC. 7 months post-op, he was incontinent at night, and then he was referred to me. He had a palpable bladder, residual urine about 800 cc with bilateral hydronephrosis. Then he had a febrile UTI. He was hospitalized, catheterized, established on CIC after control of sepsis. Continued on clean intermittent catheterization, then had another infection. So we did some urodynamics, and he had another infection.
It's 7 o'clock.
So we did another urodynamics, and as you can see, this is a lower motor neuron bladder, but he had a poor bladder compliance. The bladder pressures are steadily rising to about, this is 100, so almost 35, 40 cc's. Here.
What does this mean actually?
Poor compliance, 40 cc. 40 cc end-filled detrusor at a voided volume of, I don't know. So this is the dangerous bladder, where as the bladder fills up, his pressure has gone up to. So this is 50. So at least 35, 40 centimeters of water here. The end-filled detrusor pressure, you can see here, maximum detrusor pressure 41 centimeters of water.
What does that mean?
That is a dangerous pressure. That is a detrusor leak point. That means 40. That is high. And so we did the micturating cystectomy program, and now you can see, I don't think there was reflux, but you can see that the bladder neck was open here, and the sphincter was obstructed. This is what I was telling you of a static distal sphincter obstruction. This we have encountered not only in myelodysplastic children, but also in in this particular case. So there is a sphincter. So many of these conus lesions are mixed. Either what I see is that either you've got a supraconal lesion or a pure conal lesion with a completely flaccid bladder, or something in between where it can go either way. So this was that category. So he was back on CIC with anticholinergics and nitrofurantoin, and he was walking well. Everything okay. But he had a repeat MRI done in 2009, a year after his injury, and now he had the MRI showed there was no residual compression on the spine, but he had bilateral hydronephrosis. Irregular follow-up was a bit irregular, but he came back a year later. He was still on CIC, but having recurrent severe infections. And now see what happened on the ultrasound. The kidneys were quite hydronephrotic. Look at that. So much water in the kidneys. These are the bad bladders with upper tract damage. And he's a young man. He was 21, 22 years old. So now the MCU was repeated in 2011, 3 years after the thing. And now urine was backflowing into the right kidney. And you can see this is typical. Again, the sphincter is narrow, the bladder neck, the bladder neck is dilated. So this was a classical case of this, behaving like a detrusor sphincter dyssynergia. So we did a renogram, which again showed the right kidney was smaller and getting smaller and contracted. Urodynamics repeated again. Detrusor pressures were high, nearly 40 centimeters of water. No, 21. Anyway, whatever it is. So really, the patient was having repeated UTIs while on CIC. So these are the red flags. You are on CIC, but you are getting repeated symptomatic UTI. 2 episodes of urosepsis with right pyelonephritis, and still having urgency and urge incontinence. So eventually in 2014, we did a clam cystoplasty. And after the cystoplasty, you may appreciate from these ultrasound that the upper tracts are not so dangerously dilated anymore. And subsequent urodynamics shows that the bladders are now, the detrusor pressures are quite low. And this is not a very good tracing. So detrusor pressures are lower than what it was. So, and the kidneys are not dilated anymore. So this was one of our success stories. So this is just to illustrate actually how to recognize the warning signs of a patient having problems despite intermittent catheterization. So if you have been doing intermittent catheterization, if you don't follow up the patient, you will have problems. So,
I just need a feedback of one of our patients while someone asks you a question.
So what was the cause of hypernephrosis?
Because the bladder was poorly compliant, even though the urodynamics did not show pressures more than 40 centimeters of water, he had developed MCU showed that the external sphincter was spastic.
He was doing that,
Maybe he was not being compliant, or